Welcome everyone to this webinar. It's so wonderful to see so many of you joining from literally all over the US and all over the world. Thank you for joining, and we're delighted to see you. My name is Elizabeth Nijinsky, and I'm the Vice President and Publisher for Nursing at Springer Publishing Company in New York. For those of you who may not be familiar with Springer Publishing Company, we are an award-winning publisher of nursing and healthcare content, featuring books, apps, journals, and digital products. Today, we have the great honor of presenting What's New in Drugs and Breastfeeding with world-renowned researcher, author, and clinical pharmacologist, Dr. Thomas Hale. Dr. Hale is a professor of pediatrics and associate dean of research at Texas Tech University Health Sciences Center and acting executive director of the Infant Risk Center. Dr. Hale is considered one of the foremost experts in the field of perinatal pharmacology and the use of medications by pregnant and breastfeeding mothers, and we are delighted to have him share his research and important updates with us today. Before we get started, I wanted to mention that this webinar will be recorded. If you miss any portion of the presentation, you can find the video on Springer Publishing's website 5 to 7 days post-event. And please note that it will be available for only a week after that time. If you have any questions, please type them into the question box in your Zoom control panel, and we will address as many as we can accommodate at the end of the presentation. Now, without further ado, we are honored to turn the presentation over to Dr. Thomas Hale.
Good morning, and thank you, Elizabeth, for the introduction. I'm talking to you from the Infant Risk Center at Texas Tech University School of Medicine. We're a worldwide call center. We get calls from everywhere about drugs in pregnancy and drugs in breastfeeding moms. Today, I'm going to go through a whole host of drugs that we get and calls that we get and give you some maybe pearls of wisdom on how I make decisions about these drugs. The reality is that of all the drugs in the world, we probably have fewer than 20% of them studied in breastfeeding moms. So that means 80% of the drugs we use generally in pharmacology are not studied in breastfeeding. And so we simply have to look at the structure of the drug, look at the where it goes and how it works and how dangerous it is to make various kinds of decisions about whether we can use this in a breastfeeding mom. And so it's a rigorous decision. We get about 100 calls a day from everywhere, and probably about 10 of those end up in my office here because my nursing staff don't quite know what to say about them, and often I'm not sure I do either. But nevertheless, it's been many years of experience doing this, and I still don't know everything there is to know about this field. It's always changing and always moving. To begin with, let's start just briefly a little bit about how drugs transfer into the breast milk. We've known for many years that the organ system that makes human milk in the breast is called the alveolar apparatus. The alveolar apparatus buds off from the ductal system during the early stages of gestation, and as it grows, there's a blood supply that comes in as well, from the lobular artery. And the artery feeds a lot of blood and component stuff to the alveolar apparatus. Arrayed on the surface of the alveolus are what we call the myoepithelial cells. The myoepithelial cells contain oxytocin receptor sites. And so when the mother has a letdown, then she contracts this alveolar apparatus, and the milk is forced out into the interlobulary duct and on down towards the nipple. Now, the most important component of this alveolus is the secretory alveolar epithelium, which we have renamed to lactocyte. The lactocyte is a very beautiful cellular system. Many people think nerves and the brain is the most important and intellectual substance or group or organelle in the human body. I don't agree with that. I think the lactocyte is by far the most brilliant cell in the human body, because this cell makes hundreds and hundreds and hundreds of components in human milk de novo. It makes them from scratch. It puts in the right proteins. It controls all the electrolyte composition of milk. It controls the protein composition. It controls the lipid composition. Everything in human milk was designed to be somewhat static during the day. Nature did not intend for infants to be exposed to milk that was 1% protein at one time of the day and 10% the rest of the day. It wanted babies to get the same kind of composition of milk throughout the day. The only thing that really changes much is the triglyceride content, and that changes primarily because of its stay in the alveolar apparatus. Once the triglyceride component is secreted into milk, into the compartment here, then it undergoes lipolysis by various kinds of enzymes. And the longer it stays in the breast, the larger the triglyceride component that is metabolized and broken down. So it goes from very low content in the foremilk to very high, rich triglyceride content in the hind milk. So the alveolar apparatus is very, very important, and it's the primary component that drives the synthesis and the creation of human milk. It also drives the transfer of drugs into human milk. All drugs enter into milk as a function of their content in the capillaries surrounding the alveolar apparatus. If you have high levels of drug in the vascular capillaries, then you're going to get higher levels in breast milk. But that still doesn't mean that the levels are high. It just means that you get the transfer from the milk or from the plasma compartment is done by equilibrium forces that force drugs from a high concentration to a lower concentration, such as in the alveolar or the lactocytes. Now, we all know during the colostral phase that the lactocytes are highly spaced apart. They're not very functional, and everything in the colostral phase gets into breast milk. IgG, large molecular weight immune globulins, just everything in the plasma compartment is going to get into breast milk. But the fortunate thing about colostrum is that the volume is not that much, generally 60 to 100 cc's a day for the first 2 or 3 days. And as a consequence, then, the total dose of drug that is transferred during the colostral phase is often considered minuscule, simply because there's not a much volume of milk here. This also goes on later down in late stage lactation. When you go 12 months to 14 months, and the kind of the general volume of milk transferred at 12 to 14 months is somewhere in the 200 cc's per day. And then when you're at real late stage lactation, like at 18 months to 24 months, then most moms generally produce far less than 20 to 30 cc's of milk per day. Some may produce more, but most of them don't. And the fact that the volume of milk is so low means that the dose of the drug transferred is low as well. It's very important to remember. So when you get a call from a mom that's 1 month, 2 months, 6 months postpartum, then yes, we get concerned about the drug because the volume of milk is 700, 750 cc's a day. There's a lot of milk, there's a lot more drug. But if the mom's way out at 24 months, and we get lots of these calls, I've had calls to moms who are still breastfeeding at 4 years. Well, the reality there is that there's not much milk, therefore there's not much drug. It's always important to remember. It's one of the little cues that you always want to remember when moms are asking about various kinds of drugs. Now, then at about 4 or 5 days postpartum, the lactocytes grow all together. And once they grow together, this becomes a very, very tight compartment. And I always like to say it's like the blood-brain compartment. And the blood-brain barrier was produced to keep substances out of the brain compartment for obvious reasons. Nature wanted to make sure that toxins and substances like botulism toxin simply couldn't get into that brain compartment. Well, nature also created the breast compartment as well and made it just as tight as the brain compartment. And so we have here our second blood-brain barrier, where the lactocytes are tightly fenestrated together. And as a consequence, drugs that enter from the plasma compartment must go through 2 bilayer lipid membranes, and most drugs do not like to do that. And as a consequence, then, at about 4 to 5 days postpartum, the breast is tightened up and it's closed off. And at this time, then the usual pharmacokinetic components we talk about, such as low molecular weight, and high concentrations in the plasma, those become somewhat important at about 4 to 6 days postpartum, and certainly at 3 weeks or 4 weeks postpartum. Then this compartment is really, really tight. There's a classic old study I always love to talk about, and when this woman got botulism poisoning, she was absolutely comatose in the hospital. She was also a breastfeeding mother, and someone pumped breast milk from her, and they sent that off, and they found even though the mom was completely comatose and very sick with botulism poisoning, there was no botulism toxin in breast milk, simply because botulism toxin is about 280,000 Daltons, simply too big to get into breast milk. And so that's one of the first cues that you always learn about a drug is look at the molecular weight. Every time I see a new drug, the very first thing I always look at is what's its weight and what does it look like? What kind of a drug is it? Is it a monoclonal antibody, which has a molecular weight of 160,000 Daltons? Or is it a brand new anticonvulsant that has a molecular weight of 200 or 300 Daltons? That's the very first component that you always like to look at. The risk to the infant, I always evaluate the risk to the infant as about 3 to 4 really major factors. The choice of the drug is the first factor. If the patient is calling or the lactation consultant calls us and she says the drug is a penicillin or cephalosporin, well, we don't get too concerned about it because those drugs are not noxious. They're not dangerous really in and of themselves. If she calls about a really nasty anti-cancer drug that is noxious and toxic, or she's talking about some sort of poisoning, then we get really concerned. And that's the very first factor that you want to always cue in on and evaluate. What kind of drug, and so its overt toxicity. We call this, we have a term in pharmacology called therapeutic index. And if the therapeutic index is real small, then it's a penicillin or sulfonamide is generally safe. But if it's a real high therapeutic index, it's a noxious cancer drug. The age of the infant, we've just been through that to some degree. If it's a premature baby they're talking about, then you need to be more cautious. Premature babies, however, don't get as much milk. Their milk volume that they get from mom is generally quite small. So most premature babies I don't worry too much about for one reason, and that is because most of them are in the neonatal intensive care unit. And if they're in the NICU, I know there are nurses, there are physicians that are monitoring that baby's respiratory rate and GI tract and monitoring that baby really, really closely. So you can actually relax a little bit about some of these drugs. But again, if they're real noxious drugs and they could cause all kinds of GI problems, then you need to get concerned about it because the premature baby is a super high risk for necrotizing enterocolitis, and you certainly don't want to screw that up with some sort of medication that could be a problem. The older infant is generally at minimal, less risk. Remember that the infant's liver grows, the metabolic capacity of the liver grows at about 10% per month of life. And so a baby at birth has a really low metabolic rate. And then at 9 months, their liver is really quite functional, and as a consequence, you don't need to worry about it much. So if moms are calling about a 9-month, 12-month-old baby, well, then you don't need to be quite as concerned about it. If it's a much older infant, say 2 or 3 years of age, then basically there's not a great deal of risks. But it's the young premature babies, it's the babies that are 1 to 6 months that really get lots of milk and get a lot more drug. And those are the ones that we kind of be careful with. And the volume milk, we talked about that. Colostrum is minimal. Full breastfeeding is some risk. Late stage lactation is generally very minimal risk. Exposure in utero is kind of important. That's particularly important for opioid-like drugs because you'll be surprised, but most babies that are exposed to a lot of opiates in utero become quite dependent on them and also quite tolerant to them. So as a consequence, babies exposed in utero to opiates can generally continue to breastfeed on their mother, even though the mother is still using the opiate drug. And you need to be kind of careful with this because there are a number of little cues that we'll talk about here in a minute when we talk about opioids. But there have been some recent evidence published that suggests that actually babies that continue to breastfeed on moms that are using opioids, probably the infants have reduced withdrawal syndrome, and as a consequence of the small amounts that are still left in milk. And so it also, the last variable we always look at is what's the relative infant dose? How much really transfers into milk? If it's low, well, then we don't worry about it quite as much. And so this is just a relative infant dose calculations. We use this all the time, and we depend on it. The lower the relative infant dose, the better. If it's less than 10%, then that's really good. We have very, very few drugs that are greater than 10%. I'd say the vast majority, 95% of drugs are right about 2 to 3% of the relative infant dose. I don't know why that's true, but that seems to be what I find with most of these drugs. But there's one thing that I want to remind you, and this, I'm going to say this many times during this lecture, and that is you always ask the dose. My nurse came into my office 2 weeks ago and said, I have a mother calling about methadone. And I said, well, why are you asking about that? We get that call every day. She said, Dr. Hale, you don't understand. This mother is using 600 milligrams a day of methadone. That is 6 to 10 times the normal dose. So always ask the dose and compare that with what the dose normally is. We get many calls today from neonatologists and from other doctors, obstetricians that are taking care of a mom that's just delivered and she's using antihypertensive drugs, sometimes at 4 to 6 times the normal dose. So always ask that dose. And I've gotten really particular about the dose. It's almost the second thing I ask is, what's the drug and what is the dose that you're being used? And you need to memorize that. Most of us in the center here have that listed on our screen at all times so that we can be careful about the dose. Because when you're talking about a small dose of nifedipine or something like that, it's not a problem. But when you're using 4 to 6 times, it becomes a problem. I don't want to talk too much about birth control preparations. We've known for years that estrogen is a problem. High estrogen levels can really suppress milk production. That's pretty well known. The data in this field is horrible, absolutely horrible. There's not much data that shows too much about the effect of estrogens on the milk production. The one thing that I've thought is really kind of interesting is that you always have to have some estrogen or you can't make any milk at all. There are some anti-estrogen drugs now that are used for cancer, breast cancer in particular, and they completely wipe out estrogen levels in these individuals. And when you completely wipe out the small estrogen levels in a woman, her milk supply stops completely. So we have to have a little bit of estrogen, but we don't want really high doses of estrogen. We prefer the progestin-only mini pills, primarily because they seem to have fewer side effects in breastfeeding moms. Depo-Provera, there's not much I can tell you about it, no data on it. The data shows that it's safe in breastfeeding mothers. We may not agree with that, but that's what the data really shows. Antibiotics are basically all pretty safe to use. The only one that I really kind of worry about a little bit is erythromycin. You can get hypertrophic pyloric stenosis in a newborn, but if the baby is long past newborn stage, say the baby is 1 month, 2 months, 3 months, you don't worry about it too much. But erythromycin is known to increase the risk of hypertrophic pyloric stenosis, particularly early postpartum and also in breastfeeding moms. Doxycycline is the other one that's used for Lyme disease all the time on the East Coast of America. The CDC says they recommend it for 3 to 5 weeks, and that's probably all right. It does not stain infants' teeth too much if it's used briefly, but I had a mother call the other day that was going to use it for 6 months. And I told her she could not continue to breastfeed for that long because of the damage to the dental layer of the baby's teeth. Clindamycin is a good choice, and my choice for MRSA resistant staph, particularly in moms with Mastitis, the first choice of mastitis is always to use dicloxacillin or flucloxacillin in other countries is always the first choice. But if it doesn't work in the first day or two, then clindamycin is probably a good second choice to use. We're really getting concerned about the use of fluoroquinolines, and we do not recommend them much anymore. They're still occasionally used for urinary tract infections, but there's so much resistance there that it's really not it's not preferred much anymore. Anticonvulsants are very commonly used in breastfeeding moms. If they're used at normal doses, they are generally quite safe. The one drug I really like the most is Lamictal. And I don't own any of their stock, but it seems to be a very safe drug, even though the relative infant dose is kind of high, 9 to 18%. Babies seem to do just fine with it. But you need to be cautious. There's one thing you always watch for this, and that is rash. If the mom breaks out in a whole body rash, or if the infant breaks out in a rash while breastfeeding, that is serious. And that's something you go see the doctor about immediately, because it could be an indication of a very severe syndrome called Stevens-Johnson syndrome. It's quite rare, but always watch for a rash. I've had 2 mothers call in the last year that their babies developed a rash. And so be really careful about this one. Valproic acid is a great anticonvulsant. It is a lousy drug to use around pregnant or breastfeeding mothers. It is well known to produce all kinds of neural deficits in infants. It lowers their IQ as much as 11 to 12%. This is a bad drug to use. And also, it produces a high rate of spina bifida. And we all know that breastfeeding moms, all of them, are at risk of getting pregnant. And if they get pregnant, and while they're taking valproic acid, then the baby has a really high risk of spina bifida. And generally, the spina bifida occurs by about 4 to 6 weeks. That's before most mothers even know they're pregnant. So I recommend that you never use valproic acid in a young woman. It's just not a good idea. Levetiracetam, Keppra, and topiramate, we see these used very, very commonly. They are reasonably quite safe, and they don't cause a lot of sedation in babies. I think they're good choices. Vaccinations are all basically safe. The only 2 that we worry about a little bit is yellow fever. It's known to induce a very, very, very light case of yellow fever in the baby, and so that's been documented, but it's an attenuated virus, and the babies seem to do better. I talked to an infectious disease guy once from the CDC, and he told me, and I was asking, should mothers going to Africa and places like that where there's a lot of yellow fever, should they use this? And he said, well, it's a hell of a lot safer than the yellow fever itself. And so that's what you need to think about, that the vaccine is probably a lot safer than the native yellow fever. The other one you want to be kind of careful with is rotavirus. Rotavirus is a live virus vaccine. It's attenuated, but you need to be careful in one population, and that is mothers that are taking various kinds of monoclonal antibodies. Monoclonal antibodies range from all kinds of things. They bind with certain kinds of receptor sites. We even have some now that work for migraine headaches. But the rotavirus, the kind of monoclonal antibodies you worry about are those that suppress the immune system, like etanercept or like infliximab, or those that affect the tumor necrosis factor levels. And those situations, in the last trimester, this vaccine, this monoclonal antibody transfers extensively in utero to the baby when the baby is born. And then the baby has a full body burden of these monoclonal antibodies. I would not suggest you use rotavirus, a live vaccine, in a baby that's been exposed in utero to some of these monoclonal antibodies that affect the baby's and the mom's immune system. The analgesics are really hot subjects right now. They're the #2 call we get at this center here today. We all the time we're called about codeine and morphine and hydrocodone and fentanyl, so we get lots and lots of calls about them. The good news is that for the most part, the transfer of most of these into breast milk is not too high. You have to be very, very careful that you don't use extensively high doses. You have to be very, very careful if it's a premature baby that's subject to apnea. You have to be careful with those infants and watch and monitor their respiratory rates and watch the dose, really watch the dose in these moms. And so the babies will, after prolonged use of these, and we get calls from mothers all the time that are using this for months on end, those babies are going to be somewhat dependent upon these drugs and may actually go through withdrawal. So be kind of careful with these drugs. If they're not ideal to be used in pregnant moms, if you can avoid them, try to. But you can't always do that. And some moms will take these all during pregnancy and all during breastfeeding. Just be real careful with this family of drugs. Try to keep the dosage low and try to make sure that, that the mothers don't use random dosing intervals. I've had mothers call that only use their opiates like on Mondays and Fridays. And in those situations, the baby does not become quite tolerant. And then when the mom used this big dose on Monday, the baby could be at super high risk of apnea because of real high dose. If the mom used the same dose every single day, then I don't worry about it quite as much. And because the baby will become tolerant and dependent, but tolerant as well, and it'll do just fine. So watch the intervals. We always ask, how do you take your meds? Do you take them every single day, the same dose every single day? That's kind of critical that you ask that. Morphine has always kind of turned out to be the better choice because about 25% of it no, 75% of it is sequestered in the liver. Only 25% or less is actually bypasses the liver and gets to the infant's plasma compartment. So it's always been a pretty good choice, and the studies always show that it is a nice choice drug. Heroin users, you got to be real careful with those because you do not know the dose these mothers are using. So when a mom calls up and she's a heroin addict, she should not be breastfeeding, period, because you just don't know what kind of dose these moms are using. They don't know what dose they are using. And so it's a very risky situation. But if the mom's in the hospital on an IV pump or something like that, morphine has always turned out to be one of the better choices of analgesics for breastfeeding mothers. Methadone is quite commonly used in methadone addicts right today, and the doses we hear all the time are in the vicinity of 80 to say 160 milligrams a day. We get those calls all the time. These moms are on methadone maintenance treatments. They're using the same dose. The babies become quite tolerant to this, and they do just fine. The most important thing for the mother to remember is that if she immediately stops breastfeeding for some reason, then the baby can go through a withdrawal itself because it's getting its methadone from the milk. So moms need to be taught that they need to withdraw very, very slowly and very, very carefully off of methadone if they're going to continue to breastfeed. And if they're not going to continue to breastfeed and they just stop immediately, then the baby will probably have to be treated in the hospital for methadone withdrawal. But always ask the dose. This is the one I got this horrific dose in that really shocked me. And it really made an impression on me that we need to ask the dose because I would have said, well, methadone's quite safe to use if you use these kind of smaller doses. Here are some of the relative infant doses of all the classic drugs. To be quite honest with you, about 5 years ago, a paper came out of codeine, and there was a real concern about codeine use in breastfeeding mothers, particularly that were what we call rapid metabolizers. Codeine is not biologically active. It is converted to morphine at about 7% in normal individuals, and about upwards as 20 to 22% is converted to morphine in rapid metabolizers. So that shocked the world. The FDA came out with a black box warning: don't use don't use codeine in patients, and everybody stopped it. And then they did something that was absolutely bizarre, and they reclassified hydrocodone from a Schedule 4 drug, which everybody could write prescriptions for, to a Schedule 2 drug, which required triplicate prescriptions. And all of a sudden in the United States, almost all the prescriptions were written by residents in our institutions All of those residents couldn't write for hydrocodone anymore. And what did they do? They went back to codeine. So now there's been like 1,000% increase in codeine use in the United States simply because the FDA reclassified hydrocodone. Up to that point, the number one call we got at the Infant Risk Center was on Tylenol or acetaminophen. The number two call was on hydrocodone. I still think hydrocodone is a good choice. It's partially subject to rapid metabolism, but not completely. And I think it's a good choice. Hydromorphone, be very careful with this one. People, when they went from hydrocodone, went to hydromorphone, instantly we had a case report of some really sedated infants. And so we had to put out kind of a warning to avoid high doses of hydromorphone because of respiratory depression. It's 7 to 10 times more stronger than morphine. And the SSRI family, the antidepressants, are now been well studied. We have a lot of experience with this family. And as a consequence, we feel warm and fuzzy about them. We think they're all quite safe to use. Although I can tell you in the United States, I'd say 90% of pregnant moms are on sertraline or Zoloft. And that's simply because it's been studied in pregnant moms a lot, and obstetricians in this country really like it. I don't think there's any really good reason why they're all placed on Zoloft, but nevertheless, that's what we see all the time here in the United States. There is some withdrawal, and there's a brand new one that's just been introduced this last year, Trintellix, and my laboratories have just now published the relative infant dose of 1.84%. It's going to be quite small. That's really great. This is really a nice drug, and I think it's going to be quite popular. Right now, I'd say the vast majority of the calls we get on antidepressants are on Zoloft or sertraline. Very, very rarely do we ever get a call on paroxetine. And that's because the withdrawal effects in the newborn infant are highest with paroxetine. We know that somewhere around 15 to 20% of babies that are exposed in utero to an antidepressant will go through withdrawal. That's important to remember because you're going to get this telephone call. And I got one last week from a neonatologist here in Texas, and he said, Tom, I've got this baby that's now 3 or 4 days postpartum, and it's going through all this, looks like withdrawal symptoms. He said, but I've looked at the mom's chart, and there's no indication that the mom was on any kind of an opiate drug. And I said, yeah, that's true because that's actually withdrawal from probably from sertraline or paroxetine. He said, yes, that's right, that she was on an antidepressant. So the antidepressants sometimes can mimic the withdrawal of an opiate. Always remember to check the patient's chart, and if the doctor is thinking that this is withdrawal from an opiate that they don't know about, it could be just essentially a little mild withdrawal from sertraline. No one ever treats sertraline withdrawal or paroxetine withdrawal. Just wait a week and it goes away. We have these new ones, vortioxetine, which I just told you about, milnacipran, Festima. We don't have any data on that. Zulresso is a brand new one. It's an intravenous drug. It's actually a derivative of progesterone, and it's used intravenously. Over 60 hours is very, very effective at blocking severe postpartum depression. It is very effective, but very expensive. Very few people use it here anymore, simply because it takes a long time you have to infuse it over a long time. Ketamine is really a hot topic in the United States and around the world right now. It's a very effective treatment for treatment-resistant depression. And right now it's being used as a nasal spray. Some people are even injecting it IV for prolonged postpartum pain from various kinds of surgical procedures. But it's very effective for depression. We don't quite understand how it works, but it's quite effective. And it's sometimes used when the psychiatrists can't get anything else to work on a patient. Ketamine's the go-to drug that they almost always find effective. Neonatal withdrawal, I just told you about that, occurs in 30% of newborns exposed to sertraline and paroxetine because they're the short half-life ones. It's a discontinuation syndrome, really is what they call it. And it looks just like opiate withdrawal, but always distinguish it from an opiate. You don't want the docs to treat the baby with an opiate because they think it's an opiate withdrawal. Always remember this little cue. I get this call 3 or 4 times a year, so just try to remember it. These are drugs, we get lots and lots. Some of the top 10 drugs that we get calls about are lithium and some of these drugs right here used for bipolar syndrome. They're very effective for bipolar, but they're commonly used and you have to be somewhat careful. Again, they're extraordinarily good for valproic acid. It's extraordinarily good and effective, but it's a drug that I simply never recommend in a breastfeeding mom or in a young woman that could get pregnant. Lithium's kind of the gold standard. It works very well, but patients hate it. They have little light tremors, like an essential tremor from it, and they have dysuria or polyuria. They want to urinate constantly because of the extreme production of urine, and so they really hate this drug. And 40–50% will come off the lithium within a month or so. Many patients don't stay on it. But it can be used in breastfeeding moms. You got to be careful with this one. This is the one I always tell the mom, have your pediatrician monitor your infant lithium levels, because babies' lithium levels approach around 30–40% of the moms. So if mom stays in the right range, and then less than 1 milliequivalent. If mom stays in the right range, then the baby's probably going to be just fine and be safe. We got quite a few studies. It seems to be a relatively safe drug to use. Again, valproic acid, relative infant dose as high as about 5.6%, but this one really will drop IQ levels in babies. Don't use this around a baby. It's just not a good choice. And I got an email from a lady in Australia not too long ago who said that this mother was using valproic acid all during pregnancy and wanted to know if she could use it during breastfeeding. And I was just horrified by that. And I even suggested that the doctor ought to be censured for this, because everybody knows that valproic acid is teratogenic and you should not use it. Carbamazepine, lithium, lamotrigine, topiramate, phenytoin can be used. You want to be a little bit careful with carbamazepine and phenytoin. They've been associated with some kinds of birth defects. But lamotrigine and topiramate and lithium are reasonably good choices in breastfeeding mothers. Let's talk a little bit about cannabis now. I may go over an hour a little bit. I hope you don't mind, but this is a fun subject. The cannabis endocannabinoid system is a different nervous system in the human body. We didn't know about this until about 20 years ago when the CB1 and the CB2 receptor sites were found. What is interesting about the endocannabinoid system is that this system is what we call a retrograde control system. It has a negative feedback from the postsynaptic receptor to the presynaptic receptor, and when it feeds back, it turns the presynaptic receptor off. So you can imagine this is how it calms anxiety down. You can see how it can control pain as well, because it turns this neurotransmitters off, and that's why it seems to work. CB1 receptors are primarily in the brain and the spinal cord. CB2 receptors are primarily in the periphery, the muscle and the bones in the peripheral areas of the skin. THC, delta-9 THC, the active component from cannabis, is really powerful on the CB1 receptor. Cannabidiol, it does not interact at either of these two receptors. It has its own receptor site that it acts at. And so this is kind of a graph showing you how the retrograde inhibitor works. When you take a cannabis substance like THC or something, it signals these receptors here to secrete 2-arachidonylglycerol or anandamide, which are the two neurotransmitters in the endocannabinoid system, and they feed back and they turn off the presynaptic receptor. Kind of an interesting new neural system that we really didn't know about until about 20 years ago. Now, I don't want to talk a lot about the effect of cannabis on the fetus in pregnancy, because the reality is we just don't know a lot. There's a lot of hysterical stuff right now that you're going to read about it, but when you look right down at the odds ratios and many of the significance of the studies, you're going to find many of them are barely significant. And so, and I always love this statement from Jacques here, who's one of the individuals that writes a lot of these review articles, not real research articles, but review articles, that basically says here, he says, some of the softer neurological signs, such as aggressive behaviors or other neuropsychological problems, are difficult to attribute unequivocally to cannabis exposure due to frequently occurring negative environmental influences, such as the parental drug use, poverty, and psychiatric comorbidity. Evidence regarding the effect of perinatal cannabis exposure, that is during pregnancy and lactation, is plentiful, but unfortunately ambiguous. We're right now in this hysteria phase with cannabis. And so I'm sitting here waiting to see what really turns out. There's some evidence that released recently, I don't know if it's true or not, that it may increase, during pregnancy, may increase the risk of autism spectrum syndrome. Again, it's real weak. I just don't know if it will turn out to be true. So I'm kind of in a wait and see phase right now. But this study here was a survey of cannabis use during perinatal period. It's done in Colorado, and they looked at pregnancy and postpartum prevalence. They found about 5 to 5.7% use. It was associated with, very important, with a 50% increase in likelihood of low birth weight. Now we hear that all. The rest of the sentence is what is really important. It was associated with low birth weight and tobacco use during pregnancy. What they didn't tell you here is that in a survey we did, 45% of mothers that use cannabis while pregnant also smoked cigarettes. And we all know that cigarettes reduce birth weight in babies. We all know that. So what's doing what to who? It's not necessarily cannabis. It could be the nicotine from the cigarettes. This is a survey we did. We've not published this yet, but it's getting ready to come out. I like this because I've always wondered, why do women use this stuff? And apparently 79% of these mothers that were using cannabis during pregnancy or during breastfeeding used it for anxiety or stress, some of them for disease symptoms, and PTSD and sleep disorders were very, very rare. This number here is really telling right up here. And so it appears to me that most women use it because of anxiety and stress. Some of the beliefs, 98% believed cannabis was a natural alternative to medications. It is natural, that is true, but it's still a drug. 91% were not concerned about cannabis use. It's a very high percent. I thought there would be a higher risk because much of the rest of the population believes that there are a lot of side effects and a lot of risks from cannabis use. But the bottom line is that women are not very concerned. These women, these users are not concerned at all about cannabis in the baby. And they think their babies are absolutely normal. I know I've talked to lots of them. There is evidence that cannabis works. We do know that it works in certain syndromes, chronic pain syndrome. You can't hardly deny this. It is a pretty good antiemetic for chemotherapy. I think there are better ones that we have, better drugs like ondansetron and stuff like that work probably better. But I know a lot of moms use this for nausea and vomiting of pregnancy. And it's been used in patients with multiple sclerosis. We've got some really good wonder drugs now, some monoclonal drugs out that I think will probably supplant some of this use. But before, in previous years, we've not had a lot of really good drugs for multiple sclerosis, and cannabis was kind of popular for that. It has been used now. There's actually an indication for its use in Lennox-Gastaut syndrome and Dravet syndrome, seizure disorders in infants. These are very horrible seizures that have been to date have been untreatable largely, but cannabis, they're using cannabidiol, CBD, at rather enormous doses, and it does seem to work. The active form of cannabis, really the active form is delta-9 THC. We have a a metabolite, the 11-hydroxy metabolite. Is very slow at producing, but it hangs around a little bit longer. There is a little bit of cannabidiol, but we don't know much about how it works. It works at what we call the GPR55 receptor site and 5-HT1A receptor sites. It does not interact at CB1 or CB2 receptor sites. But delta-9 THC is generally the one that we see most common in cigarettes and things like that. That's the psychoactive agent that produces hallucinogenic response and the euphoria from the use of these. One of the things that we're seeing now is that we're seeing really, really large doses. Some people, I saw a paper out of Colorado where they were using doses as high as 75 milligrams. In the study I did, we used 20 milligrams, 23. And all the prior studies were done with 18 to 20 milligram doses. But the doses that some of these individuals use now are as high as 75 to 100 milligrams a day. And doses like that are well known to lead to psychosis, absolute paranoid psychosis. So you got to be real careful with dosing marijuana. And it's certainly not necessarily safe at super high levels. Marijuana is an interesting drug, and pharmacokinetically, I love this because when you smoke it, each time a patient takes a smoke is one of these arrows, and each time you take a smoke off the cigarette, then the plasma level rises, it reaches a peak at about 10 minutes. And then by this time, most all the delta-9 THC is gone from the cigarette due to the heat. It's been vaporized by the heat and it's gone. They can still smoke out here, but they don't get any delta-9 THC. So it goes up, and right here you see it's in the vicinity right here of 10 minutes, and the level is about 150 microgram in the patient. That's reasonably high. This was a 3.5% delta-9 THC cigarette. This was done some years ago in 1992. Now I want you to remember this dose here in the plasma compartment, 150 microgram per mil, or microgram per liter, 150 microgram per liter. Now, when we go to oral use of marijuana, what you see is that the levels are real slow. THC raises and goes down, is gone in 10 hours, not 10 minutes, 10 hours. Like from oral use, it's very slow. You get a higher concentration of the active 11-hydroxy that takes about 25 hours to get rid of all of it. And the oral absorption of THC metabolite, which is inactive, is reasonably high. But what's important about these levels here is look at this axis over here. The THC level here is 0.5 to 1 microgram or nanogram microgram per liter, and which compared to 120 microgram per liter. See the difference? There's a 100-fold difference. So oral absorption is very slow. It's quite poor. We know that patients absorb about 1% of marijuana when it's taken orally. Now that's very important for what I'm getting ready to tell you, is that the older studies were very crudely done. This mother came in, she was a heavy smoker for 7 months. She had 150 microgram per liter in her plasma compartment. We don't know when she smoked. We don't know anything. It's a very poor study pharmacokinetically. This one down right here, this mom used it 7 times a day for 8 months. She had 340 microgram per liter of THC in her breast milk. That's a lot of cannabis in her breast milk. But both of these are pharmacokinetically are just not very accurate, and we just didn't know. So my colleague and I, Dr. Baker and I, set up this study, and we went to Colorado actually to do this because they can use marijuana, purchase marijuana legally up there. And we set up this blinded study, or it wasn't blinded, but the patients were blinded to us. We did not know who these patients were. And so we set up this procedure where we gave them 1/10 of a gram. They went out and purchased 1/10 of a gram of a product called Presidential Kush. It had 23% THC in it. And so these patients were getting 23 milligrams when they smoked all of this 1/10 of a gram. And we put it in a glass pipe so that we were sure that they got the intent, almost complete 23% of the THC. You never get it all. The reality is you inhale it. Some of it is inhaled and absorbed, and some of it is exhaled into the air. But this is as accurate as we could get with a smoking situation. And so when we did this, we found that the milk levels in the mothers, we had them go home, and they went home and smoked this. And then they gave us a milk level of 20 minutes, 1 hour, 2 hours, and 4 hours. And we found that it peaked out here at about 1 hour, which was interesting to us. And we still do not understand why it didn't peak here at like a few minutes, 30 or 45 minutes, peaked out here at 1 hour, and then it was virtually gone in 4 hours. And so we looked at all the individual patients. We had 9 patients that ate, 8 patients that did this, and most mothers clustered right down here. But then we had this one right here. And the question is, what's going on with this mom? We think, our theory is that this mom was a really heavy, consistent daily user, and her volume of distribution in her body was full of cannabis, so that when she smoked this cigarette, then it all went into her plasma compartment, and super high levels went into the milk compartment. This mom had 8.7 relative infant dose compared to all these moms at 0.3. Now, the rest of the story here is that even in this mom with a high 8%, only 1% of the oral medication is absorbed in humans. We don't exactly know what the oral absorption is in the infant, but it's probably comparable, very close to that of the adult. So the babies, even though they got 2% of the medication, they only probably absorbed about less than 1% of that orally. And so our next study is going to look at chronic user moms, heavy user moms. We're going to try to go back and find more of these moms that use it 4, 5, 6 times a day and look at their milk, and so that we can find out how much actually gets into their breast milk in the heavy user mom. Now, very quickly, I want to go through some brand new stuff that's come out of the Infant Risk Center. We're starting to look at cannabidiol. We've had some problems with it because the milk levels are so low. And so we actually brought this mom in that was using it. She was using about, I think she took 5 milligrams. But the big problem is, what did she take? And so we had her bring her bottle. We took a sample of this, and this bottle was actually 100% of stated potency. And so this mom's level was, now this is 3.5 nanograms per mil. That is super, super low. And we had to use a very sophisticated instrument to even find this. So this is our very first patient we tried. So now we're going to go back with a new study design to try to measure cannabidiol levels in breast milk. I think they're going to be exceedingly low. And if a baby gets this, they're still only going to get about 1% of this. So you can see how exceedingly low the dose to the baby's going to be. We did a second mom here, and we couldn't even find it. Couldn't find it in this mom. So we looked at her bottle here, and I hope no one's taken this bottle, because we found it was 20% of stated potency. Some bottles we've looked at had no cannabidiol in them. So you got to be real careful with what you buy, and unless you actually take it into a lab and measure it to see. We did a study on aspirin. I've been asked about aspirin for years. All of us in pediatrics are worried about Rye syndrome, and we found absolutely no aspirin in milk, no aspirin at all. It really bothered me for a while until we figured it out from an old study done in 1984, that when aspirin is ingested, it's absorbed in the portal circulation in the gut. It goes directly to the liver, and 100% of it is picked up by the liver and metabolized to salicylic acid. So I was quite relieved that the aspirins in an 81, even in a 325 milligram dose, was not absorbed. No aspirin was present in human milk. That was good news. We did this one. Xarelto is an anticoagulant, rivaroxaban. We did this one. It's very commonly used now. We see it all the time. The relative infant doses are quite small, 4 and 5%. I don't think this will have any effect upon a breastfed baby. Cyclobenzaprine is a drug is used in chronic pain syndromes. Every chronic pain woman is going to have this. It's called Flexeril. It's a muscle relaxant. And we were asked about it. It's an old drug from 40 years ago, but it's really used commonly today. And so I set up this study, and we did this in 2 moms. And the good news is that relative infant dose is only 0.5% cyclobenzaprine. I worried about this one because this is a really strongly sedating drug. But the good news is it doesn't get into breast milk. We did this study on methotrexate. We published this. The good news is I always worried about this drug because it's such a strong folic acid antagonist. It's a dangerous drug. But the good news is almost nothing is present in human milk. That was really a great study. I liked this one simply because I worried about this drug for years. Cyclophosphamide is an anti-cancer drug, quite dangerous, but it's used also to suppress symptoms in multiple sclerosis. This mom gave us 4 days worth of sample, day 1, day 2, day 3, day 4. And this works out beautifully because this drug induces its own metabolism in the patient. Her levels went down and milk levels went down as well. And so I still wouldn't recommend this in a mom, but it told me that after a few days, a mom can return to breastfeeding quite safely. Mesalamine is a drug used for all different kinds of GI syndromes. Levels in milk are exceedingly low. We published this one. Montelukast is a drug that's kind of like an antihistamine drug used in babies all the time. I do not like this drug, and I no longer recommend it, but the levels in breast milk are exceedingly low. This drug has some problems right now in pediatrics. We're worried about certain kinds of syndromes cropping up with Montelukast. I don't think we should recommend this again, but nevertheless, people still use it a lot. This is a stimulant drug used for hypersomnolence, and it's used quite commonly in America. It's of the amphetamine family. We studied it, and the relative infant dose is quite low. Moms use this all the time. They use dextroamphetamine all the time. The levels are low there as well. And this is vortioxetine data, the new antidepressant. This is going to be a wonderful, popular antidepressant because it has so few side effects. Relative infant dose is great, really, really low. We got these drugs, and what I would ask your help with is that we publish the drugs we're interested in studying on our website. And if you go to the website, you'll see over there, and moms can come on there, they can click on the drug and volunteer. These mothers are just wonderful about supplying milk samples to us. And that's where all these previous studies I just showed you came from, simply because moms volunteered. We send them out a packet of vials. We tell them to take the drug and then collect a little milk sample at 1, 2, 4, 8, 12, 24 hours or whatever. And the moms fill those up, freeze them, they send them back to us, and we've got a case report out of it. And this is the place that we're getting all these new drug studies and all these wonderful moms, and also you lactation consultants that are referring these moms to us for these drug studies. We have even more of these drugs than this that we're interested in right now. So watch our website, and that's going to tell you where we're going with our new studies. This is my team now. I've just hired 2 new people to the Infant Risk Center. New Cornell graduate here, a PhD in nutrition. We're going into the nutrition component of human milk. I hired a new PharmD here to work with me on drug studies. I have this wonderful PhD biologist here that does all of our assays and all of our really sophisticated stuff. A technician works for us. And then these are my 2 RN clinicians that handle the telephone lines all the time. And they take all the calls, and they're the ones in my office all the time with difficult line. So give us a call if you have a question. And I think now we're opening for some questions if you have some time.
Yeah, that's excellent. Hi, Dr. Hale. This is Frank Costanza. So thank you very much for such an informative presentation. And I know that this large global audience we have here today, really greatly appreciates all the information you've shared. We have over 2,000 participants. So now let's take a few minutes to answer some questions. So I'm just going to start to go through these, Dr. Hale. One that popped up that I'm sure everybody's concerned about. When the COVID-19 vaccine comes out, do you recommend breastfeeding mothers get the vaccine?
Well, the answer to that is we don't know yet. We don't know which vaccine is going to come out. The current vaccine, the one we just had some problems with, is a vaccine that's derived from the adenovirus. And it's an attenuated virus, and they put the COVID proteins in that virus so that the human then makes antibodies to that COVID protein. They've had some problems with that one. I don't know how that's going to work out. I'm getting ready to start a huge trial here in Texas on a Novavax vaccine. And many of the other new vaccines that are coming out are what we call mRNA type vaccines. And this one is really kind of cool, I think, because what they did is the spike, everybody knows about the spike protein on the COVID vaccine virus. It's that little thing that sticks up, and the spike protein is what attaches to human cells. So what this company did, and I think all the rest of these companies are going to do the same thing, they took the spike protein and they went into a test tube environment and recomposed that spike vaccine synthetically. So it's a synthetic spike protein. It's not from the virus, it's synthetic, 100% synthetic. And then they put that into their vaccine, and that way I think it's going to be interesting. We don't know if it's going to work, but we think it's going to work. There's preliminary data suggests that it works. And I think that once we know that they are safe and use it in a large population, it'd be quite safe for moms to use it. But let's hold off and let's wait for a few months to see which ones are really quite safe. And then we're going to have to decide. None of these have been studied directly in infants themselves. So that's going to be, probably that'll be way into next year before we know anything about treating infants.
Thank you. What are your thoughts on the usefulness and clinical relevance of calculating an RID for monoclonal antibodies, which are given very infrequently or are poorly absorbed by the infant? I think you might have touched on this a little bit already.
Well, the monoclonal antibodies are, we do relative infant doses on them, but it's not very clear, and I'm not too certain how accurate they are. Many companies, studying drugs and substances in human milk is a difficult process. It's a nightmare, to be honest with you. And the reality, I've tried for years to get ELISA assays to work on human milk, and they don't work well at all. So it's kind of a touchy subject with me, with the monoclonals in breast milk, but I'm sure the pharmaceutical firms are very sophisticated. They can probably do a good job of it. The monoclonals, the ones you want to worry about are those that are somewhat immunosuppressive. I just saw a nice review article that looked at the GI absorption of the monoclonal antibodies in the infant. And basically, in the GI tract of a human and the GI tract of an infant, basically the absorption of monoclonals was really quite small. They calculated somewhere in the 1% range of the dose presented. So I think the monoclonals thus far, we've not had really any complications reported thus far in infants. The time you worry about the monoclonal antibody is in the last trimester of pregnancy. And in the last trimester of pregnancy, all but one of these monoclonals can transfer extensively into the baby. So when the baby is born, remember in the last trimester, they get all their immune system from mom. And there's a very potent transporter that transports the IgG molecules into the fetus. And so if that baby is born and they've got all that etanercept or infliximab or any of these monoclonal antibodies, if they have high levels of that in their plasma compartment, they're at slightly higher risk of infectious disease. Mm-hmm. And so we have to be a little careful with it.
This individual would like to know a little bit more about the safest option for treatment of H. pylori while breastfeeding.
Well, I'd have to study that. Again, they have all different cocktails now that they use, different antibiotic cocktails. I think it would kind of depend on when you're breastfeeding, early postnatally or in your late stage lactation, kind of depend. But I don't remember all of them. I remember there's some of them that have erythromycin in them, some of them have penicillins in them, some of them have sulfonamides in them. There are different ones, and I can't really It just depends on which cocktail the clinicians are using. And believe me, I think there are at least 3 different cocktails that are now recommended for H. pylori.
That makes it complex. Can Wellbutrin interfere with establishing a milk supply and or suppress milk production?
It is reputed to suppress milk production. We've seen that it reduces prolactin levels. There's another set of drug in the second generation antipsychotics, Abilify, which I thought was always a wonderful drug because it has the least weight gain in that family. But it turns out that it suppresses prolactin levels as well. So Wellbutrin and Abilify are complications or problems in moms, particularly if they have a difficulty with the breast milk supply. So I'd be real cautious with those 2 drugs.
Okay. Let's see. I'd love some information about hypertensive drugs and breastfeeding for moms who develop postpartum preeclampsia.
Well, this is oftentimes when we encounter drugs which are used at horrifically large doses postpartum. The beta blockers, you have to be quite careful with ace-butylol and atenolol. Those have been reported to produce apnea in children and sedation in newborn infants. So you got to be real careful with the 2 A's. The calcium channel blockers, such as nifedipine, or calcium channel blockers are generally okay to use. And some of the other beta blockers are all right to use. But again, you got to watch that dose. And that's what I get these, and they're very concerning to me because I get often telephone calls where they're using these antihypertensives at 3 and 4 times the normal dose.
Mm-hmm.
It's
So
most often that they use those in the last trimester when the mom has severe hypertension. And then early postnatally, they start dropping those off. But still, within the first few days, the first week, the mom still may be on really super high doses. So you got to be quite careful. You got to be quite careful in premature babies with exposure to lisinopril or the ACE inhibitors because it could suppress renal function, renal growth and maturation. So you got to be kind of careful with the ACE inhibitor. But the calcium channel blockers are pretty safe. Most of the beta blockers are pretty safe. But again, you have to judge. And one of the things I often do, I'll mention, is when I get really concerned that the doses are high and the risk is really high, I often suggest that moms go half and half breast milk, half donor milk, or half formula. Go half and half. That'll drop the dose right there, 50%. And they may do that for a week or 2 weeks until they can reduce their dose of the drug or till the baby gets older and more viable and can tolerate those drugs a little bit better. That's a technique, a tool I use all the time. Instead of just saying, just don't breastfeed, I just say, well, go half and half for a while and see, watch the baby closely and tell them what's to watch the baby for, sedation, poor feeding, difficulty to arouse, and symptoms like that. But don't ever just say, just don't breastfeed. The only time I ever do that is with super high levels of iodine or radioactive iodine, or certain radioactive drugs. We just say, just don't breastfeed, just don't do it. But other drugs, most of the time we can, if we have with a half and half technique, seems to work reasonably well.
Excellent. All right. Just a few more. Would colostrum harvesting from a mother on medication expose the baby to a higher dose in the breast milk?
Well, the dose in the colostrum is generally going to be higher anytime, but because the breast is so open and so porous to that. And so I never do colostrum studies simply because it would be a misconception because you probably find a lot of the drug in the colostrum. There are very, 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 very few drugs, but because the breast is so open, I generally don't do studies in that. But the reality is that the volume of milk is so low that you're lucky if your baby's getting 60 cc's of colostrum the first 2 days or 3 days. And as a consequence, the clinical dose to the baby is just really low.
Mm-hmm.
And so I think the first 3 or 4 days that you don't need to worry so much about most of these drugs.
And one final question. This kind of touches back to cannabis and CBD. This individual is asking if there's information on CBD oils. And the individual is curious on how breast milk and the baby are affected by a mom using CBD oil.
Well, CBD comes in all different formulations. Almost always, because it is an extremely expensive product, and it's also extremely lipid soluble. It always comes in oil. You can barely pick up a bottle that doesn't have it formulated in olive oil or one of the vegetable oils. And so it's always dispensed in oils, almost always. I did see one product that was put in a polymer, polyethylene glycol or something like that formulation. But basically, there's always some sort of oil that it comes in. And so regardless of what the oil is, the cannabidiol is going to be admixed, and you dose according to, it's generally, they'll put a little bit small, really small, few milligrams of cannabidiol in there, and then they'll put it into an ounce of vegetable oil. So the baby's getting lots of vegetable oil. It won't bother it at all. The one thing that really does bother me, though, is that people are recommending the topical application of cannabidiol and THC, and I think that's, to me as a pharmacologist, that's really stupid. And it's because we do not know if those things are absorbed transcutaneously. It's just not known. No one's done those studies. And one of the things about formulation of drug products that I've known for many, many years is that if you're going to formulate a product that goes through the skin, it has to have certain excipients in there, that certain lipid type products that will transfer the drug through the lipid layers of the skin, the corneum layers of the skin. And there are very few drugs you find. We know that we can get fentanyl, but it's formulated in a product that has these special ingredients that make drugs go through the skin. But if you just throw cannabidiol in oil and scrape it on or rub it on the skin, we do not know that any of it is absorbed. Just don't.
All right. Yeah. Well, thank you very much, Dr. Hale. This has been absolutely so informative, and I know everybody truly appreciates all of the information you've provided. For everyone on the screen, you can see there's some special offers. We do encourage you to visit halesmed.com for a free trial of Hale's Meds online, or visit springerpub.com for a 25% discount on the latest issue of Hale's Medications and Mother's Milk. And you can see the discount code on the screen. And as we've been mentioning, we're going to provide a recording of this webinar about 5 days after the webinar, but it will only be available for a week, so from about September 17th to the 25th. So look for that webinar on our site. Following this webinar, we'll do a couple of things. We're going to send out a survey. I'd love to get your feedback and share that with Dr. Hale and his team. We will also get to all of these questions. We'll summarize these, we'll provide them to Dr. Hale, and we'll do our best to get some answers to these. Again, Dr. Hale, thank you so much.
You're welcome. You're welcome.
We really appreciate it. This global audience, it's been a pleasure presenting to you. And well, have a wonderful day, everyone. And goodbye for now.